So this is next slide, right? Good evening, everybody. I'll start off tonight's case presentation with the first case. Okay, so my case is a 61-year-old lady. She first presented with complaints of left parietal painless swelling for 5 months, progressively increasing in size. 2 weeks later, she presented with a right-sided hemiparesis, and this was associated with neurological weakness of the right upper and lower limbs. She was limping and had an unstable gait, and she had history of frequent falls at home. She was also bedbound with buttock shuffling. So we also noted that she had an anterior neck swelling for 30 years. It was slow growing, no sudden rapid increase in size. There was no compressive symptoms. There was no hyper or hypothyroid symptoms, and she didn't have any hoarseness of voice. So regarding her past medical history, she had underlying hypertension and she had poor compliance to her medication. Family history-wise, there was no family history of malignancy, and social history, nothing really significant. So this is the patient. This is the picture of the patient. And there's a neck swelling, and anterior neck swelling.
So that's variation of the swelling.
The swelling looks elongated, but there's no skin changes, no diabetes. It's central. But it's like, I'm not sure, maybe the picture is the color. It's hypopigmented at the low part of the swelling at the neck. And there's a bulging, obvious push scar swelling at the posterior part of the hip. Okay, so on examination, neck examination, there's a left thyroid nodule 8x6 cm. It was hard inconsistency. Trachea was deviated to the right, and there was no palpable lymph nodes. Head examination, there's a left temporal parietal swelling 8x8 cm. It's firm, fixed to the scalp, and non-tender. Clinically, the patient was euthyroid. This is the thyroid function.
Teaches what you think especially.
So one, for the thyroid function, obviously she's hypothyroid. With the neck swelling, with the suspicious scalp swelling, we worry about thyroid cancer, metastatic thyroid cancer.
So how about this thyroid function test?
So with this thyroid function test, I go primarily to treat hypothyroidism. So start comes 20 milligram PDS.
Much?
20 milligram PDS.
What is the dose you can give thimerosal? Okay, what is the side effect that you afraid to start by just
The suppression of the itself. Granulocytosis.
So based on this Saturday, what are you going to do?
Then I will repeat the thyroid function test few weeks time, and then 4 weeks time. And then I will do some like thyroid, CT scan, This is the contrasted CT of the neck.
So you have to look at that.
From the CT scan, I can see there's a enlargement on the thyroid node, especially on the left side. It looks like it has a multiple nodules. If the trachea is being deviated to the side to the right side, however, the trachea still remains patterned. And on the CT scan also, there's no obvious retrocernal extension. And it appears hypodense at one side and hyperdense on the part of the thyroid. Even the right side is large, but it's more towards the left side. It's heterogeneously enhanced. The vessels looks all patterns. I don't see any enlargement program there.
Yeah, I don't think so. Comment how about the figures?
So because
Anything you
because I think it's still better than see at the whole part. No obvious any.
yeah, the part you can see, right?
The upper part I can't really see. Maybe it's compressed.
Okay, next, this is the CT that you see. Any other imaging that you want to do?
Based on the CT, I would like to assess this thyroid ultrasound, see any such. Because ultrasound will be able to assess whether the thyroid nodules the features.
Right. Anything else? I got the CT brain.
Yeah, CT brain as well.
Anybody want to comment on CT brain? Next.
Pass the mic.
On the city brain itself, there is an also scalp disease have an intracranial extension to the brain at the region of parietal and occipital.
CT sun and now. You want to comment anything about the way?
It is a lung nodule on the right side. So bilaterally, the nodule about 1 cm.
Right, based on this CT next, and you see the lung nodule also. So what you want to do for this patient?
First, apply the concrete diagnosis,
Right.
whether it is a differentiated parasite and aplasia, because it's possible enough to see as well.
Alright.
So I'll have to do a biopsy, look at biopsy.
That is how about the scalp?
I would for the scalp itself, I will discuss this with my
urocity as well, or there is intracranial extension, where there is biopsy or not.
All right, and then next, CT, MRI as well.
That is. Prof. Una, this one.
There is a slight changes in management in care. We don't do core biopsy necessarily because we go by, because this is a thyroid. The first one it maps to the brain, to the skull. The first one is follicular cancer. Yes, you can have anaplastic. Anaplastic in the skull quite rare, right? So I will go first for FNAC because if you do FNAC, if the cellular update is very good, you can make a diagnosis of anaplastic, right? And also, if you have follicular, if you do FNAC, you can have follicular neoplasm, and that is good enough to say this is a follicular carcinoma. Even you get core biopsy from the thyroid, it can still cannot, difficult to say whether this is follicular carcinoma because sometimes you need to have invasion, right? Uh, yes, you can have, but you must remember because if you try to get biopsy, core biopsy from the bone, it is a heavily, it can lead heavily because it follicular carcinoma tends to be. Kalau you nak, you bolehlah cuba, tapi ya, tapi usually kita jarang ambil, right? But if you want to take from the brain, from the scalp, you need to do the staining as well. Okay.
In terms of Chuka and FNAC, as the huge, I mean, a large thyroid mass, actually there is a study comparing the FNAC and the Chuka biopsy. They are favoring more of Chuka biopsy. Why? Because if you Chuka, you can diagnose as if you know, so let's say that this patient doesn't have a scalp, because for example, this adenoma, there's huge mass. Yes, FNAC can diagnose. We call this anaplastic, but not, I believe the study is around 35% compared to 2000. At the same time, they can diagnose metastatic other disease of the thyroid, which is around 16%, according to the study. So it's not wrong to do FNAC, it's not wrong also to do TUCA. But if you want to do TUCA biopsy, you need to do your own ultrasound, because you need to get guided TUCA because you don't want to hit the cell. Right. Yeah.
So the CT brain and neck showed that there are features suggestive of a large malignant left thyroid mass with focal infiltration into the esophagus and distant metastasis to the lungs and skull bones with intracranial extension. There was a filling defect within the superior sagittal sinus suggestive of thrombus. An MRI was done and there was a left parietal mass with bone destruction, intracranial, extracranial component, mass effect and cerebral edema likely to be metastasis. And the mass increased in vascularity on MRA, MRV, and there was a small enhancing scalp lesion at the left occipital, possible metastatic deposit as well. So we proceeded with a true cut biopsy of the thyroid done under ultrasound guidance, and the true cut biopsy of the scalp was also done at the same setting. For those having difficulty to read, let me read it out for you. Levels show tumor tissue infiltrated by malignant follicular cells arranged predominantly in microfollicular pattern, forming sheets. The cells exhibit mild to moderately pleomorphic rounded hyperchromatic nuclei with moderate amount cytoplasm. Most of the follicles contain thick eosinophilic colloid material. There are no nuclear features of papillary thyroid carcinoma. The adjacent benign thyroid tissue was seen and no capsular area included in A, which was the thyroid, no bone tissue observed in B, which was the skull, and no obvious lymphovascular invasion. TTF1 immunostain is positive.
This obviously is follicular thyroid because of follicular lesion, and also there is no spinal cells. This is about prostate. So based on this dimension, considered follicular carcinoma. Let's say that the patient doesn't have a scar metastasis, just thyroid mass alone. Do you agree that they come up with the follicular carcinoma based on this? Let's say your pathologists come up with this follicular carcinoma. Do you agree with this actually?
No, because it was initially mentioned that there is no capsule included in the sample, so we can't really see any capsule invasion to say that it is carcinoma.
So you actually cannot diagnose follicular carcinoma based on the pregnancy as well as the because you need the capsular and also the vascular invasion to diagnose follicular carcinoma. So what the next step that you can do, honey? She had garment, she had remits, garments, she had prostitution to the lung and the brain, and also she had esophageal infection. So you're going to do surgery for her?
Yes. Yes.
I think I will tell the patient, this patient we discussed in my previous meeting, especially number one, for the radical surgery. Number one, input that I would expect to ask them is whether this is acceptable, whether we can use it to help her. If and then because of the local invasion of the arthritis, we put on but it seems that quite locally invasive. Most likely, we have palliative yeah.
Yeah, I mean, what's the guy that you want to do? Maybe this is a different question.
First option of PKI would be Levima. It's anti-jet mechanism. And I don't have experience using it, but it's using reducing dose strategy. It has two strengths about the dose. 20 and 40.
You have 34, 20, and 14, also 10 milligram.
Yeah.
So usually, when you refer, usually your nuclear physician will start this.
And we have to monitor 50s when we start the Levima because patient might have tubular fistula and other complication heart. And we monitor the heart.
The most common complication is hypertension. Some patients have a rash or overtime. So do you think that surgery is similar to
I would say we cannot get the yeah, I mean probably we cannot get KMG. So we can do bulk surgery also.
He said we can't do curative session because of locally advanced and also the metastasis. So And then we start this question about the need. So we will hope that it's true on the screen and we'll need deep imaging to redo that vision. Okay, that's all.